Chapter 7. The Effect of Traditional Cancer Treatments on the Cancer Immune Response. The Good, the Bad, and the Ugly.
Clearly, I think every cancer patient knows their basic traditional options for cancer treatment. If cancer is caught early, it is often surgery, probably with chemotherapy and radiation to follow, that is typically prescribed. If cancer is caught late, or if the patient was treated early, but the cancer has nonetheless progressed, treatment options generally are going to center around chemotherapy, radiation, and maybe the combination of both. I am a traditionally trained doctor, but I am not a fan of these treatment options. I have seen the results firsthand, and in general, they are pretty disappointing. Patients would like a more effective therapy, hopefully with fewer side effects. Our main goal is to eliminate these treatments that seem rather barbaric. More and more patients are questioning the logic of these treatments instead of following their doctor's recommendation blindly. The cancer system is very hesitant to get away from these therapies. Immunotherapy has come on the scene and is becoming accepted at a fast pace. And its acceptance in large part is patient-driven. Patients see the ads, hear the success stories, and question their doctor about getting immunotherapy. Still, in most cases, even though the results with immunotherapy are better, it is often held back until oncologists can get a few courses of chemo and radiation in first. To me, this is like saying, yes, we have something that works better, but let's try the stuff that doesn't work well first. And then later, we can try something that might work better. Oh, and we are going to beat up your body first, so that later, your chances of immunotherapy working will be even less. This clearly makes no sense. The healthcare industry is addicted to chemotherapy and radiation, just like the energy industry is addicted to oil. It is for this reason that the system is slow to change. I have to admit, to completely abandon the current treatments is something that would create an economic crisis. And for that reason, the changes will be gradual. That being said, the immunotherapy industry is going to be big business in its own right. Big Pharma is already getting themselves well entrenched as the change is coming, though the hospitals and the doctors are still lagging behind. However, enough on those aspects. Our goal here is to give you the information to enhance your treatment success. So, can chemotherapy and radiation be used to your advantage? Yes, it can. Could it be that chemotherapy and radiation may be detrimental to immunotherapy treatments? Yes, to that also. There is still a lot for us to understand about the interaction of these traditional treatments and immunotherapy. I will try to guide you to make the most out of these combinations. The reality is that most cancer patients, if they stay inside the standard healthcare system, whether it is for convenience or insurance coverage, are probably going to get chemotherapy. Let's make the most out of it. Chemotherapy and the immune response. In general, it has been recognized that chemotherapy will suppress the immune system. Certainly, decreased white blood counts are a common issue with chemotherapy. However, even in the face of decreasing the white blood cells counts, chemotherapy can have immune-stimulating aspects. This certainly seems like a contradiction until we remember that the immune system has two faces, one that attacks tumors and one that protects them. So, if you can weaken the protecting side, regulatory cells that include TREGs and MDSCSs, more, then you can end up with a net positive in the overall anti-cancer immune response. In addition, killing cancer is like reducing its troops, making it more susceptible. It is like a war. You can have death on both sides that are fighting, but if there is more death on the opposing side, you are winning. So, what are some of the effects that chemotherapy can have that are beneficial? One is immunogenic tumor cell death by mechanisms that cause a release of tumor antigens and stimulate danger signals. Tumors dying by these methods can help enhance an immune response. In addition, Cancer, as it is growing, produces many immune-inhibiting substances, both by direct protein production and byproducts of its own metabolism. If you directly suppress cancer growth with chemotherapy, you can reduce these, making the job for the immune system easier. There are certain chemotherapy agents that may be associated with increasing the immune response. I will address this directly. This being said, if you are going to get treated with chemotherapy and you have an option of different drugs, you may want to keep in mind ones that can have a more positive effect on the immune response. Also, if you are going to get chemotherapy, you really need to try to take advantage of the potential synergy with immunotherapy. I know this is easier said than done, as most oncologists have not gotten on board with this combination therapy. In addition, low and frequently dosed chemotherapy, called metronomic dosing, seems to be superior when it comes to stimulating an immune response. Sadly, this is not how oncologists usually administer chemotherapy. A combination of immune checkpoint inhibition with metronomic chemotherapy as a way of targeting therapy-resistant cancer cells. An article published in the International Journal of Molecular Sciences, October 13, 2017, discussed how metronomic chemotherapy can reduce tumor growth, which reduces immune-suppressing metabolic byproducts such as lactic acid. It can also decrease tumor angiogenesis, regulatory immune cells, and also inhibit the tissue stroma that may actually be supporting the cancer. As much as we all would like to see chemotherapy become a distant memory, it still can have its uses, especially in the current immunotherapy situation. If the patient has very bulky advanced cancer, they may need the help of some chemotherapy to get it more under control for the immune system to have a fighting chance. Otherwise, an advanced and rapid growing cancer can actually outpace the immune system. The cancer has usually had a significant head start, so chemo may slow it down, allowing the immune system to catch up. I want to stress that if chemotherapy is what you need, you should strongly look into the low-dose metronomic chemotherapy since it can achieve many of the goals of slowing cancer and may boost the anti-cancer immune response. What follows is a look at some of the most commonly used chemotherapy drugs. Gemcitabine. Gemcitabine has been shown to cause tumor cell death that stimulates an immune response. It also can decrease regulatory cells such as Tregs and MDSCSs. An article published by Zhao et al. Immunology, Let, 2017, demonstrated that gemcitabine could decrease Tregs, reduce suppressive cytokines such as TGFB, and increase stimulatory cytokines such as interferon gamma. This was in low-dose therapy in mice. As mentioned, the immune-stimulating aspects of chemotherapy seem to occur when it is used with frequent low dosing, metronomic. This certainly requires further study, but this goes against the typical chemotherapy dosing scheme that uses a maximum tolerant dose therapy, which is intermittent but high dosing. 5-fluorouracil, 5-FU. 5-FU, also in low-dose fashion, was shown in animal studies to enhance the immune response by increasing antigen presentation. However, Wu et al. Published in BMC Immunology, September 20, 2016, research showing that repeated doses of 5-FU impaired the anti-cancer immune response of T cells as opposed to a single dose. Again, most studies are supporting the low dose or limited chemotherapy may enhance an immune response. The problem is getting an oncologist who is willing to give chemotherapy in this manner. Cyclophosphamide. Low-dose cyclophosphamide has also been shown to enhance an anti-cancer immune response. In a study published by Skur et al. In Clinical Cancer Research, November 15, 2017, they showed that low-dose cyclophosphamide induced an anti-tumor T-cell response in metastatic colorectal cancer that was associated with increased survival. Levy et al. From Johns Hopkins published in the Journal of Pharmacology and Experimental Therapeutics 2009 that low-dose cyclophosphamide unmasked the anti-metastatic effect of local tumor cryoablation. This study showed that cryoablation with cyclophosphamide, but not surgery, demonstrated a systematic anti-cancer immune response. In the animal model of metastatic colorectal cancer, survival rate achieved by using cyclophosphamide plus cryoablation was shown to be 50% compared to 0% when combined with surgery or versus cryoablation alone. One common dosing regimen is to use 50 milligrams by mouth every other day. This has little, if any, toxicity and high ease of use since it is in a pill form. We often use this regimen ourselves, especially when combined with cryoablation. Doxorubicin. Doxorubicin is a chemotherapy agent that works by interfering with DNA replication. It originated from soil bacteria and is considered an anti-tumor antibiotic. It generally has a bad reputation for its side effects. Besides bone marrow suppression and hair loss, toxicity to the heart can be a major problem. It is red in color and often is called red death. On the positive side, it does seem to have some immune-stimulating aspects by killing tumors in a manner that may attract the immune system. At this time, there is not much data of the combination of doxorubicin with immunotherapy, but as with other chemo drugs, we would expect a low dose to stimulate the immune response and have reduced side effects. Radiation therapy and the effect on the immune response. Like certain aspects of chemotherapy and ablation, radiation will cause tumor killing, and the resultant dead pieces of tumor can act as antigens delivered to the immune system. In general, radiation therapy may be considered immunosuppressive, but when combined with immunotherapy, there seems to be synergy. I will admit that I am biased, and I feel that cryoablation is superior to radiation in its ability to stimulate an immune response. However, it will be easier for an average patient to obtain radiation than cryoablation. It is just a sheer numbers and insurance game. There is a lot more radiation therapy available than cryoablation. Insurance coverage for radiation is generally much easier to come by than for cryoablation. So, we might as well make use of what we have available. If you are to get radiation, it would probably serve you well to also have immunotherapy. But even though there is good evidence for the combination, getting a doctor willing to actually do it is easier said than done. Again, cryoablation certainly would be my first choice, but let's explore radiation further. One area we have not discussed much is something called MHCI, which is expressed on the cell surface. The job of MHCI is to present to immune cells internal peptides that may be foreign. Think of it almost like a distress signal. This is presented to the immune system so that it will know if it needs to destroy the cell or not. It is almost as if the immune system was searching for someone and the cell presents its ID. If the ID matches the person it's looking for, in this case, cancer, then the cell is destroyed. In some cases, the cancer can escape by not having MHC on the surface. Think of it like the cancer having a fake ID, so the immune system gives it a pass. Radiation therapy can make cells that are hiding their MHC show it again. Radiation can also activate the stimulator of interferon genes, STING, pathways, which can stimulate a non-specific innate immune response. On the downside, it can cause the release of TGF-B and VEGF, which are both immune suppressive. Also, radiation can reduce white blood count, which is associated with immune suppression. There are numerous studies looking at the combination of radiation and immunotherapy. There are still some issues to be sorted out, such as determining what dose and how frequently radiation therapy should be administered. What is the timing of immunotherapy before, after, during? There are some conflicting studies related to these treatments' details. I suspect in the next couple of years these will get worked out. However, I hope in the next couple of years the need for radiation therapy will be significantly diminished as it is replaced with more effective treatments with less side effects. I might add that I have personally seen cases where patients were failing with immunotherapy, then when radiation was added, the immune response kicked in. So there are some real potential benefits, and certainly patients who are failing or have failed immunotherapy might want to consider adding in radiation to potentially activate the immune response. As you have seen from this chapter, there may be some benefits to be gained from traditional older cancer treatments, such as chemotherapy and radiation, associated with an anti-cancer immune response. There are currently numerous studies underway. The one thing to consider when it comes to chemotherapy is that most studies are focused on the traditional delivery method of maximum tolerated dose chemotherapy, but the science points in the direction of a lower but more frequent dosing as being superior. There are doctors that offer a low-dose, metronomic chemotherapy, but most are not your traditional oncologist, so you may have to do some searching. In addition, for a patient with advanced bulky disease, chemotherapy and radiation may be useful to decrease the tumor burden, making it easier for your immune system to fight. There is still more to be learned about the timing of administration. For example, certain mouse studies have shown that cyclophosphamide given before chemotherapy, such as doxorubicin, may stimulate an anti-cancer immune response, but the reverse actually suppresses the immune response. These types of findings can be variable depending on a cancer type and location, as well as the local tumor immune environment, all of which can greatly affect the responses. Though it is still being evaluated, I have seen at immunology meetings presentations discussing when maximum dose chemotherapy is used first, it may reduce the potential success of immunotherapy when used later. This most likely is related to the long-term immune suppression. Make sure to discuss low-dose metronomic chemotherapy with your doctor, and hopefully they'll be willing to oblige. It may be a good idea to go armed with studies. One good review is by Wu, Cancer Letters 2018, Immunogenic Chemotherapy, Dose and Schedule Dependence and Combination with Immunotherapy. I wish you the best of luck in convincing them. It may not only help you, but many future patients as well.